Spiegel, and Dr. Sundip Karsan will be presenting now.
Great. Thank you, Mr. Chairman, ladies and gentlemen. I'm pleased to present to you the findings of our study that evaluated the impact of early changes in blood urea nitrogen on mortality in acute gastrointestinal hemorrhage. We know that risk stratification in GI hemorrhage depends on a range of clinical and biochemical variables. BUN is traditionally used as a marker for prerenal azotemia, and as such can be a surrogate marker for blood loss and hypovolemia. While some validated risk scoring tools in GI hemorrhage include BUN, they do not address delta BUN and the role that dynamic changes in BUN can have on risk stratification. To date, the most recent international consensus guidelines do not provide recommendations regarding delta BUN and its role in guiding resuscitative and endoscopic interventions. Evolving data in other disease processes suggest that dynamic changes in BUN may have predictive value in volume-sensitive conditions. Specifically, data in pancreatitis, a classic volume-sensitive condition, suggests delta BUN is predictive of mortality. It is unclear, however, whether delta BUN is associated with mortality in GI hemorrhage, also a volume-sensitive condition. So that motivated us to do this study, in which we performed a retrospective analysis to measure the adjusted impact of delta BUN in the first 24 hours on in-hospital mortality in all comers with acute GI hemorrhage. To do this study, we used a retrospective database that was a tailored database specifically designed to measure the process to outcomes links in acute GI hemorrhage. The data come from the West Los Angeles VA Medical Center, the primary VA inpatient site for West Los Angeles. In this study, we wanted to emulate clinical reality because at the time of presentation, we do not know the etiology of the bleed. All we know is that they are acutely bleeding. Therefore, our study included all patients who presented with variceal, non-variceal, upper and lower bleeding, either as inpatients or to the emergency department requiring hospitalization. Now, we performed this analysis using a conceptual framework based upon a review of the literature, and we wanted to make sure that our database included a wide range of data elements, including patient characteristics, paying special attention to comorbidities that could affect BUN, such as renal disease, cirrhosis, and congestive heart failure. Data at the time of hemorrhage, collected at the time of index evaluation, such as those listed here. Medical and transfusional therapies, including transfusion of blood products and certain medications pertinent to GI hemorrhage. And lastly, endoscopic data, including time to any endoscopy, potential findings during endoscopy, and hemostasis. Our primary analysis measured the unadjusted relationship between 24-hour delta BUN, which we defined as the second BUN value minus the triage or initial BUN at evaluation within a 24-hour period, and in-hospital mortality. We know that there are a wide variety of confounders that can undermine this relationship. We therefore attempted to adjust for a wide variety of confounders and isolate the independent effect of delta BUN on mortality. So here's some information about 814 patients in our study. The patients were 64 years of age on average and 98% male, which is consistent with the population in the VA in West Los Angeles. Their comorbidity index is slightly greater than 3, and 17% of these cases were inpatient bleeds. 18% were found to have variceal bleeding. The average decline in BUN was 3.6 milligrams per deciliter within the first 24 hours, and 63% of the cohort had an admission BUN of greater than 20 milligrams per deciliter. 30-day rebleeding was 8.8%, and mortality was 9.6%. So let's start looking at the data. To start off, we wanted to see if there was a relationship between triage BUN and mortality. In unadjusted analysis, the average triage BUN for the 9.6% of patients within our cohort who died was 51 milligrams per deciliter, compared to 31 milligrams per deciliter in the cohort who survived. This difference in the unadjusted analysis was statistically significant. However, after adjusting for confounders, this difference was not statistically significant. What about delta BUN? In the group that died, there was an increase in the mean delta BUN of 1 milligram per deciliter. In comparison, in the cohort that survived, there was a decrease in the mean delta BUN of 4 milligrams per deciliter within 24 hours. This difference was statistically significant. In logistic regression, adjusting for renal disease, cirrhosis, and other comorbidities and covariates, there was a 3% increase in odds of mortality for every 1 milligram per deciliter rise in BUN over 24 hours. Or another way to look at it, a 30% increase in odds of mortality for every 10 milligrams per deciliter increase in BUN. This was statistically significant. These findings suggest that a rise in BUN within the first 24 hours after evaluation is associated with an increased odds of mortality. So in conclusion, Mr. Chairman, ladies and gentlemen, in a comprehensive database adjusting for a wide range of confounders, we found a strong independent relationship between 24-hour delta BUN and mortality. These data corroborate similar findings in patients with acute pancreatitis, suggesting that delta BUN may have wider applicability. As BUN is routinely measured as part of initial triage in acute GI hemorrhage and often repeated within 24 hours, delta BUN is a readily available predictor of mortality and may be used to underscore the need for aggressive resuscitation in these patients. Our findings suggest that BUN is a surrogate marker for severity of illness and plays a role in risk stratification and management of patients presenting with GI hemorrhage. These findings further emphasize the need for early, aggressive fluid resuscitation and possible hemostasis. We recognize this study has important limitations. It is a retrospective study that ensures inevitable and irremovable bias, something that we are highly cognizant of. Despite our best efforts, it is in fact impossible to control for everything. Yet, this study provides some pilot data that delta BUN within the first 24 hours after evaluation can assist in risk stratification and clinical management, and it supports a future prospective study to investigate this question further. I would like to thank all of those who have participated in the study, our PI, Dr. Spiegel, and all of those individuals who have supported our project through CORE and CURE. Thank you.
Speakers now open for questions.
Thank you. That was a very smart idea and very well conducted. I would be even more confident if tell me that you adjusted for the time, the interval between the first urea BUN and the second one. And I'm saying that because in a patient who is critically sickly, seems to be more sick and seems to have more risk factors for rebleeding and worse outcomes. If I was the resident, I would be tempted to do the second urea BUN sample even sooner before I actually see any difference because of the resuscitation. Well, in a patient who seems to be doing well, I would rather wait. So do we actually measure the way we act on a patient that seems to be high risk, or do we actually measure something that reflects the actual process of somebody being high risk?
So it's a good question, and we do have that data from when it was actually measured to what time the second BUN value was. But the purpose of our study really was to risk stratify within 24 hours. And we attempted to control for severity of bleed, including controlling for things such as we showed earlier, whether or not they required an ICU stay, whether or not they were hypotensive, whether or not they had increased transfusion requirements, etc. So we attempted to control for severity of illness, so to speak, at the time of admission. And our goal really was to just look at it within the first 24 hours, but your suggestion is well taken, and perhaps we can look at that.
Nina Abraham, Houston, Texas. I'd also like to congratulate you and your group for a very smart study, providing some objective evidence for something that we've been teaching for a long time, which is the importance of normalizing the BUN to ensure appropriate resuscitation. Now, given this data that you have, I'd be interested in knowing if you stratified or done an analysis to stratify variceal versus non-variceal bleeding. Because as you know, in a variceal bleeder, it may not be advantageous to be so aggressively resuscitating the patient to normalize the BUN. And if you have done that analysis, did you see any changes in your mortality data?
So we actually, 18% of our population was variceal bleeding. And in the initial analysis, when we first did stratify by variceal and non-variceal, we actually didn't see a difference in mortality. But again, the purpose of this particular study was really to look at all comers, because as stated earlier, it's really at the initial time of presentation when we don't know whether or not it's a variceal or a non-variceal bleed, whether or not this data can help you risk stratify the patient. But yes, we did initially look at that. Dr. Wu?
Reaching Wu from Los Angeles. Thank you for that very nice presentation. I'm very excited about your results because my own personal bias is that I believe BUN is an underutilized marker and has many additional implications to how it's traditionally been used. In upper gastrointestinal hemorrhage in particular, I'd be interested in seeing the interaction with the hemoglobin, whether there's an independent effect or is it closely track the change in hemoglobin. Did you look at that at all in some of your analyses?
So we did not look at that one-to-one relationship to see whether or not the BUN would track with the hemoglobin. It's something that we can certainly look at because we do have those granular variables.
Because I think that would be particularly telling to know whether this is related to the blood loss or other processes.
We have a little time, so I'll ask you one question. Nicely done. You point out that prospective validation is necessary. I would also add that it would be nice to know whether this can lead to actions that actually change outcome. The assumption here is that you would resuscitate a group more aggressively than another group. But the question I have for you, if I remember correctly, the discrimination in terms of the absolute value was a rise in 1 versus a fall in -4 in those who died. Yeah, in the delta. And that's not a lot. So do you think people are going to say, I'm going to treat this patient differently because his BUN went from 40 to 41 versus this one went from 36 to 33?
Yeah, that's a good point. When you look at the absolute numbers, they're not that impressive when you say it's just a rise in 1 or 2. I think the idea is to look at directionality. And that is what really should guide whether or not you're adequately resuscitating the patient and whether or not that can have downstream effects. Especially mortality and certainly the other things that we can look at downstream effects, including hospitalization and things of that sort. But I agree with you, it's not the actual delta that was more interesting, is kind of the directionality of it, and to see that actually
Very good, thank you very much.